Hello and welcome. I can see we have some attendees joining us. If you would like to put your name, just introduce yourself and tell us who you are and where you're joining us from in the chat box, that would be great because we do like to know who you are and to say hello. Hello, I see a hand up from one of our attendees. Do you want to, are you able to make yourself known either in the chat box or by unmuting yourself if you can?
The chat may be disabled, Victoria, for the participants because it's a webinar. So they just put their questions in the Q&A.
Okay, thank you. So yes, if you just want to introduce yourself in the Q&A, just so we can get a sense of who you are and where you're joining us from, that would be great. Fantastic. Good morning, everybody, or good morning, good afternoon, and good evening from wherever you are in the world. We are going to start our session at the top of the hour because we've got a lot to cover. But in the meantime, if you just want to introduce yourself in the Q&A box, that would be great. I will start in 1 minute's time. Thank you everyone for introducing yourselves. It is fantastic to see the spread across the world of people who are joining us today. And I really hope that you're going to enjoy this session and find it a fruitful experience. Good morning, good afternoon, and good evening. Greetings to everyone, wherever you are in the world. My name is Victoria Hewitt, and I have the great honour of presenting to you, on behalf of the International Association for Hospice and Palliative Care, this virtual side event for the 76th session of the World Health Assembly, titled Palliative Care, Health for All, Agenda 2030. So, this year is the 75th anniversary of the World Health Assembly, and the theme of it is Health for All. We are also approaching the midpoint of the 2030 Agenda 2030, and which is a collective journey towards achieving the UN Sustainable Development Goals. Health is a complete state of physical, mental, and social well-being. Palliative care is not just about death and dying. It is very much about health. It's about the health of all people in all settings, including health emergencies. It's about the health of the families, the caregivers that look after the people at end of life. It's about the health of communities, the health of the care workforce, and the health of the planet. And this last point is increasingly being recognised due to palliative care's role in reducing unnecessary consumption. Palliative care is recognised as a core component of universal health coverage. And yet, in the world today, most people who need it do not receive it. And most who have access to the medicines they need to relieve pain and suffering don't have access to them either. Too many people are suffering unnecessarily. The IAHPC's vision is a world free from health-related suffering, and by that we mean suffering which is serious, which is associated with illness or injury of any kind, and which can only be relieved with professional intervention. The International Association for Hospice and Palliative Care is a global membership organisation. We work across all settings and at all levels to make palliative care happen. And you will meet some of our members today. And we hope that in doing so, you'll be inspired to join us. And you'll notice that on the slides, I've included a link to our website and a QR code if you should feel that you want to join us. But it's worth knowing at this point that the fees are based on the socio-economic level of the country in which you live. So, I was proud to be an IAHPC delegate at the World Health Assembly this year, and I saw firsthand the stakes of our advocacy. And I will draw your attention on this slide to a hot off the press picture, which was taken just within the hour almost, with Natalie Greaves, our delegate from Barbados, with Dr. Tedros. So the fact that IAHPC is advocating for palliative care at the World Health Assembly is really important, but we have still much work to do. Our panel and all our IAHPC members, our panel are all IAHPC members, and they're going to talk to you about how they're addressing some of the issues that we are advocating for. Maria Adelaida and Hanan are going to address the continuing issue of access to medicines in palliative care. Joseph will highlight the role of institutions in making positive change happen. And Danielle is going to show us the importance of palliative care leadership in the COVID response. And this is an area which still fails to be recognised by member states. Before I introduce you to all of our panelists, I'm going to take you through some housekeeping. The chat function is not open, but the Q&A section is, and hopefully you're all using that to introduce yourselves, because we love to know who you are and where you are joining us from. Please put your questions in the Q&A section, and you can do that as the panelists are talking. And once they've all spoken, we will put the questions to them. Please, if you do get the opportunity to speak, can you put your microphone, can you unmute yourself, but leave yourself on mute if you're not speaking. Closed captioning is available, and a recording will be available after this event. So after my introduction, I'm going to introduce you to our panelists, and I'm going to start with Dr. Maria Adelaida Cordoba. Dr. Cordoba is a Colombian pediatric palliative care physician. She's currently the board president of the Colombian Association for Palliative Care. She's an IAHPC focal point for Colombia, and she holds one of our leadership development grants. She advocates for palliative care and medication access in Colombia. Over to you, Dr. Maria Adelaida.
Thank you, Victoria. Thank you, everyone. Thanks for being here and for the invitation. I'm the president of ASOCUPAC, Colombian Association of Palliative Care. One of the missions of the association is to advocate and improve access to palliative care in different regions of the country. I'm going to speak about Colombia access to palliative care in a specific region, Magdalena. Colombia has an estimated population of 50 million people. Although Colombia is striving to achieve universal health coverage and palliative care is included until 2014 for people with chronic non-communicable and terminal diseases for all age groups, we have very low geographic dispersion services, and currently we have 4.7% territorial coverage. I'm going to share the story of Juana. She was a 7-year-old and she was from Aracataca, Magdalena. She was diagnosed with a brain tumor and received care in Cartagena, a city in a different state. Eventually, things were not going well, so she was transferred to Bogota, the capital of the country. Finally, her cancer became incurable, and she wanted to go home and be there with her family and friends. But because we don't have palliative care, no access to opioid medication, the family and the healthcare team made the decision to take her care in Bogota, away from her siblings and friends. And finally, she died here, not being able to share her days of life with her family. So Magdalena is a Colombian state in the Caribbean region. It has around 1.5 million inhabitants and a highly heterogeneous population. We have indigenous, Afro-Colombian population and migrant population, a lot from Venezuela. Magdalena has diminished barriers to health access, but palliative care access is low, and it is as it is in many other regions in Colombia. ASOCUPAC has started a project to improve access to palliative care in Magdalena with the support of the LEAD program of IAHPC. ASOCUPAC, the Palliative Care Association of Colombia, acknowledges health systems cannot be built without integrating the different levels and organizations. A multi-sectoral conversation of the opportunities to promote palliative care activities in Magdalena was essential to define regional priorities. An alliance between members of the healthcare teams and interested civil society to identify barriers and develop actions to improve access to palliative care services. So based on the public health care model of the WHO, we started a conversation to identify the barriers in Magdalena and the opportunities to improve palliative care. We carried out meetings with the key actors. So we identified under public policy one barrier that was very important. Palliative care is not included in the health agenda for the state, but we also find some opportunities. Items within the agenda can be strengthened with palliative care. They have 3 programs that we've been working with: home medicine, doctor to your house; 2, access to patients with disabilities to timely medical services, and the development of telehealth. We do find that we have a lot of medication limited in access. We only have very low morphine and other opioids in the region. So we identified a barrier that was regional budget we did not have enough to buy medications from the National Fund of Narcotics. And they had a lot of difficulties coordinating the integration of purchase of medication, storage of medications, and delivery of medicines to people. But we also find opportunities. They were willing to adjust the budget for the next year, and they are able to design direct methods to purchase from the National Fund of Narcotics so that they can have medication in the big hospitals. We also have the development of a joint group with local authorities to train pharmacists so that they can actually deliver medication. In the Education Acts, what we find is that we have a lot of lack of knowledge about appropriate prescription in the Magdalena region from doctors and nurses. There's a lack of knowledge in the management of basic symptoms in palliative care, and there is no training in palliative care and nursing medical schools. So we did find that we have resources for training. They have a university which has a medical school and a nursing school, and they're open to the inclusion of palliative care training in the curricular reforms they had planned for the next year. They also have been able to access training through the courses and diploma courses that by ASOCUPAC in alliance with the University of Magdalena. So far, the ASOCUPAC partnership with local team members has enabled the training of 20 health team members. And also what we find is that we're designing a workshop together with ASOCUPAC, the National Fund of Narcotics, and the university to teach appropriate opioid prescription. So the outcome that we expect is actually increasing access using these three axes. The takeaways of this is that the availability of a legal framework that favors palliative care does not translate into service delivery for patients. So it is necessary to develop strategic alliances with key actors in the regions to develop programs that recognize regional resources and allow the identification of the fundamental points that limit access. The leadership of National Palliative Care Association is fundamental in the development of these alliances, as it allows the coordination of each of the actors with the capacity to advise on each of the lines of action to improve access to palliative care. Also, that patients like Juana can be cared for at home and not far away from their family. This is a list of resources that we have in the country to see how is our current situation. Thank you very much for this space, and thank you for listening to our experience.
Thank you, Maria Adelaida. Now I'm going to go on to our next panelist, and thank you also everyone who has said hello in the Q&A section. Please come forward with your questions if you have any. We'll come to them at the end. But for now, I'm going to move on to our next panelist, which is Dr. Hanan Saka Hasboun. Hanan is Assistant Professor at Tarek Jafali Faculty of Nursing and Health Sciences at Bethlehem University in Palestine. She advocates for improving palliative care in Palestine, similar to neighboring countries of Israel and Jordan, and she encourages policymakers to initiate palliative care throughout Palestine. She is also, like me, board member of IAHPC and was a delegate at WHA 76. You need to unmute, Hanan.
Good afternoon. Thank you, IAHPC and Bethlehem University, for this opportunity to present in the side event. As you can see, I'm going to talk about palliative care in Palestinian territories. The picture of Palestine, when we see it's the yellow color, it is the Palestinian people, the Arabs. This is the West Bank, and we have the Gaza. We are all considered occupational territories. We don't have easy movement between Gaza and West Bank. So Jerusalem is just in the middle of Palestine where services are offered. Bethlehem is a little bit closer to it. It's like a 15-minute drive. You have to have a permission to go from one West Bank area to Jerusalem to receive the care. Overview. I'm going to talk about the context of cancer, then the current situation of palliative care in Palestine, challenges in providing palliative care, the bright spots that we have in Palestine, what are the necessary responses, and the takeaway. First, the context of the population of the West Bank. We have 5 million people in West Bank and Gaza. In 2020, 3,191 cancer cases were reported in West Bank and Gaza. After comparing these cases diagnosed in 2020 with 3,174 cases diagnosed in 2019, it turns out that there is a 5% increase of cancer cases in 2020. For all cancer sites combined, the crude incident rate is 115.18 per 100,000 population in 2020. In 2020, cancer deaths were 14% for all fatalities, and the mortality has rose 14% between 2016 and 2020, and 136% between 2000 and 2016. So the burden of non-communicable diseases has been increasing. The current situation in Palestine, the policymaker goals is to promote PC, and it's still unclear and debatable. There has no crisis policies, and it's dependent on the individual non-governmental organization to practice, and the hospital are doing PC is Augusta Victoria Hospital in East Jerusalem, and all patients from the Palestinian government are referred, but there has been a lot of restriction. Challenges. The scarcity of medication at the Palestinian Cancer Facility is the largest obstacle in providing palliative care. For example, the gastrointestinal medication, pain medication were among the reported missing medication. Furthermore, there has been a lot of studies with patients and their needs compared to what's going on in developed country. We did notice that there was significant symptom load because of difficulty obtaining both painkillers and psychological assistance. Most of the people are getting treatment out of pocket or private insurance, and there is no palliative care association. When we look at one of the evidence that has been done previously, we see that in Palestine, we barely have one. You can see Palestine is on this side. We have only one palliative care or two, compared to other countries where we have 26. These are the Eastern Mediterranean region. Also, we have all, other than the number of palliative care services that are bubbled in blue, we have the colored state or country in the yellow. It states how much is the use of morphine in milligram per capita per year. So if we look at Palestine, we really have the 0.384 milligram per capita per year. So that means people are suffering in Palestine. The challenges, it is an isolated palliative care delivery, which is characterized by the development of palliative care activism, and it's still patchy in scope and not well supported. The funding are heavily donor dependent, and the limited number of palliative care services is affecting. The scarcity of medication, when we talk about limited medication, we have a Sadir Society that is working with Augusta Victoria Hospital to refer patients for treatment and getting palliative care. The challenges, Dr. Najajre he is the one that is taking care of oncology patient in Bejala Hospital, governmental hospital. When I asked him about how is palliative care, he mentioned that he who's the one that handle all interaction with patient and family, and there are no multidisciplinary team, and the patient receive no palliative care. The bright spot. In 2008, As-Sadir Society is a non-governmental organization in Bethlehem, started palliative care, where its main goal was to raise awareness for the value of palliative care and incorporating them into the health system. Its work entails small-scale follow-up of cancer and other chronic diseases and residents, and they are collaborating with Augusta Victoria to refer patients. They offer other services like play for the children and tamkeen for families who lost their husbands. The other bright spot is the palliative care team that has developed in 2019 at Augusta Victoria. Augusta Victoria is a Lutheran church supported by the Lutheran Church in America. They have introduced cancer care to the West Bank and Gaza in 2006. In 2019, they had to introduce the palliative care because they wanted to support a holistic program to support patients who are critically ill. The patient, they are receiving good care, good pain management, good pain symptom. And they are also giving home services to patients who are living in Ramallah and in Gaza. This services is their employee are locating within the city. They are living this way, they can give the care to the needy. Necessary response is capacity building. Bethlehem University was the one that initiated programs to build palliative care. They had graduated 3 cohorts of postgraduate diploma, and now they are currently teaching a master program in oncology and palliative care. Furthermore, there has been workshops and short courses within several non-governmental organizations, and it's funded by the international donors, and at times the organization are doing the training. The huge problem is that the donor agenda at times is not what the organization would like to get. We ask, why is it so difficult to advance PC in Palestine? There are multiple factors, but one of the most important factors, palliative care has not been incorporated into the national healthcare system. Although some Palestinian ministry officials claim that this was on their agenda, the coronavirus has shifted ministry health priorities. Restarting is therefore necessary with PC to be their priority. Now, I'm going to just mention that in memory of those who died without receiving palliative care, I'm going to talk about Karim, who was 4 years old, who's from Ramallah, West Bank. He received chemotherapy treatment for his kidney cancer, and it was not successful. So he needed aggressive therapy that affected his immune system, and he was very sick all the time. He was sent home, and the parents struggled to see him very sick. Later, the parents were very courageous and discussed with the doctor about stopping treatment because they did not want their son to suffer. It was the best choice, where Karim received medication chemotherapy at low dose, and he was able to be with his family at home and the support of everybody. As we see, patients, young or old in Palestine, frequently return home from the hospital and mostly rely on the assistance and care of their families. Since the sick patients and their families frequently cannot bear the burden of the physical and financial strain, as well as the mental stress that is linked with chronic disease like cancer, it's thought that this kind of circumstances cannot persist for an extended period of time. This is a positive case where family are the ones who requested to take an action. Takeaway. In conclusion, although the Palestinian Ministry of Health is taking steps to improve oncology care, there is still much work to be done. It is critical to ensure that all citizens have access and adequate to pain management and palliative care. Continuing to train nurses with advanced degree in palliative care is vital to enhance patient. My takeaway is, if we do not take the steps to make the changes, who will do it and when? There is a lot of evidence about challenges and barriers to start PC. We need to have it priority within the next 2 years. We need to deliver a good PC program in the country. In hope to get better prepared, we need to act. If we don't improve quality of health, we need to improve quality of death. We should not invent the wheel. We can move to action of what has been done in other countries after placing the policies and strategies. I leave you at this point. Thank you.
Thank you, Hanan. Our next speaker is another of IAHPC's Leadership Development Programme grantees. Dr. Mwate Joseph Chaela is a member of the Zambia Medical Association, ZMA. He is currently the project lead for 2 ZMA grants on palliative care and lung cancer from the Lung Ambition Alliance through the Charities Aid Foundation. He co-led the team that developed Zambia's first National Palliative Care Strategic Plan, 2021 to 26. Over to you, Joseph.
Thank you very much, Victoria. Can you confirm if you're seeing my slides?
We are seeing your slides.
Thank you. Yes, so my presentation will focus on advocacy groups for palliative care, and I'll share a perspective from Zambia. So this will be my outline. I'll look at the context, then our advocacy story, then I'll briefly talk about our national strategic plan for palliative care, then some successes that we have scored in the last couple of years, and our takeaway messages. So Zambia is a relatively young country with a population of 19.6 million. This was according to our last census done around August last year. Then we have seen the need for the increase in palliative care in the country, as we record close to 14,000 new cancer cases every year, of which cervical cancer accounts for about 24% of these cancers. Then also we see that the HIV prevalence has remained high, currently sitting at 11% in adults that are aged aged 15 years and above. Then we have also seen from initially a high burden of infectious diseases. The epidemics is changing now, where we are seeing a lot of non-communicable diseases such as hypertension, diabetes, leading to strokes, hence the need for increased palliative care. Then recently, we launched our first ever national strategic plan for palliative care. What has been our story? Our story started about 20 years ago with Palliative Care Alliance Zambia, or PICAS, who were our first or so palliative care advocacy group. And their motto was caring beyond duty, and really invested quite a lot in terms of education for healthcare workers to be trained in either diplomas or the basics of palliative care. On the upper right of my slide, that was me with a few of my colleagues about 15 years or so, 10 years ago, when we did our palliative care training at Makerere University. What came after the training, we saw a number of hospitals within the country are formulating palliative care groups with a lot of technical assistance, training support from the Palliative Care Association of Zambia. We even commemorated some of the World Palliative Care Day commemoration. And down on the right of my slide is PCAS went ahead to even
Okay, we seem to have temporarily lost Joseph. What a shame.
which unfortunately, hello, can you hear me?
Yeah, no, we just lost you temporarily, Joseph. Do you want to just
Sure.
go back a little bit?
Oh, thank you. Yeah, which unfortunately, I was talking about the National Palliative Care Strategic Plan, which was supposed to run from 2013 to 2015. But unfortunately, this was never officially adopted by the Ministry of Health because it was around the same time that PCAS was reducing its scope and shutting down its doors due to limited funding, which was mainly donor dependent. But what happened after PCAS? From the success stories that PCAS did, a few of the people that were trained in palliative care made a contribution to the National Cancer Control Strategic Plan for 2021, for 2016 to 2021. And in this strategy, it looked at 4 cancers: cervical cancer, prostate, retinoblastoma, breast cancer, and palliative care. We saw that for the first time, a complete chapter in a strategic plan was included in palliative care. After that, a few of the staff that were trained by Palliative Care Association of Zambia went ahead to even advance in more palliative care education. We started seeing some publication coming out of the work that we did, and also representation at national conferences and other international conferences as well. Then we were also included in the International Association for Hospice and Palliative Care advocacy group, where Zambia was co-opted into a group of about 6 countries. And after all this work, even about a decade since PCAS reduced its scope of work in the country, its legacy still remains in the picture that you see below of healthcare workers who were mentored and trained by PCAS. And eventually, it is this team that went ahead to produce Zambia's first national palliative care strategy, which is running from 2021 to 2026. And this is on the 26th of May in 2021, when our palliative care strategic plan was officially launched by the then permanent secretary and his director for clinical services, Dr. Kenneth Marama and Dr. Makupe, respectively. And in a nutshell, when we look at our national strategic plan, it is anchored on the WHO framework, on the building blocks, and we focus on health, workforce, commodities, infrastructure and equipment, health financing, and delivery of palliative care services. On governance and leadership, it also highlights the creation of the Zambia Hospice and Palliative Care Alliance. And in this strategy, it is indicated that the Zambia Medical Association, who at the time when this strategy was being developed, were key in providing some of the human resource and technical expertise are listed to be anchored as the secretariat. And so what will be the role of ZAPCA? ZAPCA will perform similar functions as PCAS did. It will primarily focus on driving the palliative care inclusion advocacy in the country. Or the health systems within the country to ensure that palliative care is integrated within the health systems as it is outlined in our National Palliative Care Strategic Plan. What have been other successes? We have so far received 2 grants. The first was from the International Association for Hospice and Palliative Care, which will help us in the actualization of ZAPCA as an alliance, as an institution, and will be anchored by the Zambia Medical Association. Hence, the grant was passed on to the Zambia Medical Association. Further, we received an additional $25,000 from the Lung Ambition Alliance. Primarily, it's an initiative in lung cancer care. And among the treatment aspect is the issue to do with palliative care. And it is through these 2 grants that we are going to help actualize the presence of palliative care advocates in the country. We have also continued to be called at key national stakeholder meetings. The Health Professions Council of Zambia is our medical board, which is responsible for registering all healthcare workers, apart from the nurses, as well as all healthcare institutions and training institutions. And they have called us for a meeting that starts tomorrow for us to participate in the development of palliative care guidelines to ensure that we have a coordinated approach as we provide palliative care services. Further, as part of our work with IAHPC, we went ahead to make a publication on advocacy with palliative care. And this publication, which was released in October last year, it talks about, can you hear us now? Equity in global advocates for palliative care. And in this document on Zambia, we briefly talk about the successes of the palliative care strategy and what we hope to achieve. Then after the strategic plan was launched, the government released the resources to support the development of a palliative care curriculum, a short palliative care curriculum. And that's the team that you see at the bottom, who were the first team to sit to just create a palliative care training in basic palliative care so that we can begin to roll out the palliative care needs in this country. With that said, what is our takeaway message? We have seen that, and when the government ensures that they have policies and institutional frameworks such as our National Strategic Plan, it becomes very easy for palliative care to be integrated in the health system because we have seen that shortly after the development of the strategy, the government was mandated to start releasing specific resources towards palliative care integration in country, such as the resources that were released to support the creation of the training materials. Then we have seen also that institutional structures for advocacy are important, as is the case for PCAS. We are riding on the strides that PCAS made in the 10 years or so that they worked actively in this country. And therefore we foresee that reactivating PCAS and also the creation of ZAPCA will further continue to close the palliative care advocacy gaps. And as seen, we see that it will be very, very easy for us to continue integrating palliative care into the government systems. These are some of the resources that we used, and these are acknowledgements that go to the government of the Republic of Zambia, PEPFAR through CDC for some of the funding that went in towards the development of the palliative care strategic plan, then PCAS, on whose legacy we relied on, and indeed IAHPC for their continued support and collaboration. Thank you.
Thank you, Joseph. Just before I move on to our next speaker, I have noticed that there is one hand up in the chat from Nicola Whippy, if you have a oh, it's gone down. I'm assuming it was a legacy hand then. If you want to put your question in the Q&A section, then we'll come to it at the end. But please, always happy to have any of your questions or comments. So keep the chat coming. Our next speaker is Dr. Danielle Sola Lopez. She is a Brazilian palliative care physician, and she's IAHPC's advocacy focal point for Brazil. Over to you, Danielle. Danielle, you're on mute.
Thank you, Victoria. Good morning, good afternoon, good evening, everyone, and welcome to my presentation about the role of Brazilian palliative care workers in the COVID pandemic. Today, I'm honored to present an overview of the exceptional work done by our dedicated palliative care providers in Brazil. Through evidence and testimonials from my brave, competent, and compassionate colleagues, we will explore into the strategies these teams employ to overcome COVID-19 challenges. The presentation focus on 4 distinct palliative care settings, showcasing the triumphs and the obstacles faced by these professionals. Before delving into these settings, I will briefly introduce the palliative care situation in Brazil. Brazil is a vast and diverse country with a complex landscape spanning 8 million square kilometers and housing around 209 million people across 5 regions. The nation's healthcare discussions begins with the recognition of health as a fundamental right in the Brazilian Constitution and through international treaties. However, access to palliative care remains insufficient for many Brazilians, with a lack of integrated services across all healthcare levels. The healthcare system in Brazil operates under a mixed and segmented structure comprising public and private subsystems. The public system ensures universal access. The second edition of the Global Atlas of Palliative Care in End of Life, released in 2020 by the World Health Organization and the Worldwide Hospice Palliative Care Alliance, shows significant advancements in providing palliative care. But Brazil progressed from isolated availability in 2014 to a more widespread presence in 2020. However, much work still needs to be done compared to other nations. According to the Brazilian Association of Palliative Care, there are approximately 192 palliative care services, but they are highly unequal distributed across the country. Now let's move to the COVID pandemic. Of September 5th, in 2020, 4 million cases and 126,000 deaths in general population were confirmed in Brazil, with 75% of the victims being elderly. Unfortunately, in times of pandemic, health inequalities become even more evident and often worsen. In my research and discussions with my colleagues, I heard their concerns about the potential oversight of palliative care in the COVID-19 triage systems during the COVID-19 pandemic. In that time, the government's declaration of a public health emergency prompted discussions on healthcare prioritization and resource allocation. Brazilian intensivists were already familiar with the difficult task of deciding which patients to admit to limited intensive care unit beds. But this difficult task of deciding which patients to admit to limited ICU beds was familiar, particularly work in the public hospitals. And leaving such decisions to a single person is responsible and introduces the risk of bias. This challenge was not unique to Brazil. So with all we will talk about in mind, let's explore the inspiring success of the history of Mirella Rebelo, a palliative care physician. She developed a tool to prioritize patients for intensive care unit referral in COVID-related severe acute respiratory syndrome cases. This ensured equitable care, preventing exclusion and reducing suffering. Her accomplishments influenced policymakers and gained recognition, leading to implementation throughout the entire state of Pernambuco. Now let's shift our focus to the innovative activities at the Central Institute of Hospital das Clínicas out of the Faculty of Medicine of the University of São Paulo. This hospital played a crucial role in delivering exceptional palliative care to severe COVID-19 patients, serving as the largest referral hospital in Latin America for such cases. Under Dr. Ricardo Carvalho's leadership, the group has implemented World Health Organization's recommendations for integrating palliative care in humanitarian crises. They developed a triage protocol for identifying palliative care needs and mortality risk. This protocol prioritizes referring high-risk patients to the palliative care unit instead to the intensive care unit, optimizing resources allocation. Also, a round-the-clock hotline and the use of tablets and robots equipped with tablets improved the communication and relieved burdens. The success of these actions is evident through publications and conferences, presentations recognized by peers. Now met one of the patients under compassionate care of Dr. Carvalho and his dedicated palliative care team. We know that urgency of saving lives often takes precedence in the healthcare system during humanitarian emergencies. However, it is vital to remember that other crucial aspects must be considered. Each patient face tells a unique story. The pain they endure, physical symptoms they experience, the fear of the mortality, or maybe concerns for loved ones at home. As a compassionate healthcare providers, we understand that alleviating physical and psychological suffering, addressing social distress, and nurturing spiritual well-being are equally significant to save lives, ethically and medically. Now let's shift our attention to another remarkable case that exemplified the transformative power of innovative approach in healthcare. Here, a public-private partnership was established between the mentioned hospital we previously talked and the Sírio-Libanês, a top healthcare institution in Brazil. This partnership aimed to integrate palliative care into the intensive care units. Dr. Daniel Fortes, an esteemed palliative care leader in Brazil, was appointed as the chief of this initiative, leading these integration efforts. Under Dr. Fortes' guidance, the team developed the hierarchy of communication needs, an innovative communication strategy during the pandemic. It received positive feedback and recognition of the annual Assembly of Hospice and Palliative Care Conference this year. And also Dr. Fortes shared his experience at Harvard, highlighting the significant impact of this groundbreaking approach in healthcare communication. Here is Dr. Fortes working in the intensive care unit. And now the third notable success case highlights the remarkable contribution of Mirlan Cardoso. Mirlan, a dedicated palliative care worker in Manaus, ensured uninterrupted care for cancer patients during the pandemic. Through advocacy and dedication, she convinced her managers to prioritize palliative care, preserving patients' dignity and treatment. Her persistence played a pivotal role in sustaining these crucial efforts. Well, palliative care teams encounter varied challenges. However, the pandemic also highlighted the tremendous worth of the palliative care workers on a global scale. The 4 cases presented exemplify the remarkable leadership of palliative care providers on the front lines of the pandemic in important cities and healthcare centers throughout Brazil. These providers displayed exceptional innovation in their patient care approach, consistently upholding ethical principles. Their deep knowledge of alleviating suffering, transparency in decision-making, and unwavering compassion set them apart in their dedication to provide the best possible care. Our Brazilian dedicated palliative care professionals followed these guidelines that the World Health Organization recommendations, ensuring compassionate care aligned with international standards. The COVID-19 pandemic taught us the significance of the palliative care and the need for preparedness and innovative strategies during the crisis. We advocate for palliative care to be an integral part of the future pandemic plans, acknowledging its role in alleviating suffering and promoting dignity. It is imperative for policymakers to equip themselves with the knowledge and insights provided by the World Health Organization Guide to Humanitarian Crisis and the Living Guidance in order to prepare for future pandemics effectively. By advocating for this inclusion, we empower healthcare systems to provide comprehensive care to individuals facing several illnesses, even in the challenging circumstances. And finally, a heartfelt thank you for our esteemed palliative care colleagues, including the dedicated palliative workers at INCA, remarkable efforts of Dr. Inês Tavares in Fortaleza, exceptional leadership of André and at the NCP, and at the countless others. Those invaluable contributions could be discussed due to time constraints. Thank you so much.
Thank you, Danielle. And you're quite right, we could have talked for another hour, but we only have this hour together, so we have had to be conscious of time. We have had some questions in the Q&A section, some of which I know Catherine, who's working behind the scenes, has been working hard to answer. But one I thought was particularly of interest to you, the panelists, and it comes from Zodwa Gamedzi, I hope I've got your name right, from Eswatini Hospice at Home. And the question was really around the training of nurses and other health professionals in opioid prescribing. Those of you in the panel who've got experience of that, what advice would you give to somebody who is just about to start out on a training program for healthcare professionals, specifically around opioid prescribing? Hanan, do you want to answer that?
Yes, actually, we had one of the nurses that, because we are undeveloped country, he got training in another organization, and he received like a certificate that he can order medication. They have to get permission from the ministry that he will be a nurse clinician, can order medication. The hospital has changed their strategy and had put a policy that he will be able to. So it was a three items: the government getting a license, the hospital has to put the policy, and the person has to get enough training to be able to transcribe medication and the follow-up. Thank you.
Thank you. And Joseph, have you had similar experiences in this area?
Yeah, so from the African perspective, Uganda has been more of our trendsetters because of their developed palliative care systems and how well they have integrated palliative care. So from the Zambian perspective, currently only physicians like myself are allowed to prescribe opioids. Other healthcare workers are not allowed to prescribe opioids, and this could be similar in most African countries. And as such, for Uganda, what they did is, one, they trained their healthcare workers, the nurses, the clinical officers, those that are below the physician, and went ahead to change government policy to ensure that opioid prescription can be done by non-physicians. So I think even in Zambia, what is inhibiting the prescription of opioids by non-physician is the policies that we have. So it will begin by changing some of those policies. And indeed, Uganda has got a lot of wealth of information where we can learn. And deliberately for Zambia, we have put that in our strategic plan under leadership and governance because we realize that the expansion of palliative care services, especially with regards to treatment of chronic pain. And so for Eswatini, you may need to go through a similar situation, and we can share contacts with the Ugandan team that have been doing this for quite a while, and their nurses are able to prescribe. Thank you.
Thank you. I am conscious that we are coming to the, Catherine, yes?
Yeah, I just wanted to say, hi, everybody, that the World Health Organization, as well as the International Narcotics Control Board and the UN Office of Drugs and Crime, the Commission on Narcotic Drugs Secretariat, recommend task sharing and nurse prescribing by appropriately trained healthcare personnel. So the Uganda model really is getting uptake with the international organizations.
Thank you, Catherine. I am conscious that we are coming to the top of the hour, but we do have some more questions. So we are going to stay on the call to talk and to answer your questions. For those of you who cannot stay, I want to thank you very much for joining us. It has been an absolute pleasure to be part of this, and I want to say thank you to our panelists for so generously sharing their stories and experiences with us today. I would like to just comment that I think the takeaway for me from hearing your presentations has been the importance of having a national palliative care organisation. We can see from the experiences in Brazil and Colombia, and obviously what Joseph's doing in Zambia, and also where there are where there is a palliative care organisation, or where you're in the process of setting one up, but also from Hanan and the challenges that you are facing in the absence of such an organisation. So for me, that would be one point that I would really hope that everybody on the call can take away. So thank you for those of you who've joined and who can't stay with us for any longer, because we're coming to the end of the hour. If you want to stay, please feel free to do so. And I'm now going to go through some more questions. And there is one from Sandali, who is asking would like to know how Zambia can go about providing home-based palliative care. So this is one for you, Joseph. Any challenges and how are you overcoming them?
Yeah, thank you very much for one model that we have used in Livingstone. Livingstone is a province. It's our tourist town in Zambia. For those that have heard about the Victoria Falls, that is where it is housed. It's a neighboring town with Zimbabwe. Yes, so what we did in Livingston, we identified what community-based activities towards the provision of care were going through within the districts. So what happened is we created the palliative care team at the hospital. Then we did an analysis to see what community structures were available to support community services. So we identified a home-based care team that had been providing palliative care services and other services within the community. And also we identified a hospice within the district. So what we did was we linked these three entities into one, and we have been able to move patients from the hospital to the hospice and to the community. And since in terms of training, most of the professionally trained palliative care providers were housed at the hospital. So what was happening is, or what happens is, these particular individuals do go to the communities. Once a client is discharged, they have drawn a timetable with the hospice as well as with the community-based team to follow through these clients. So this is one model that is happening in Livingston, as well as another hospital within the southern part of Zambia in Mazabuka, and also across the country. Then also now when it comes to bigger hospitals, like our biggest hospital for palliative care provision is the Cancer Diseases Hospital, which is based in the capital city. And its focus is primarily tertiary care, but we have civil society organizations that work with the hospital to provide palliative care services at community level. Thank you.
Thank you. And here's a question for Maria, Adelaida, and Danielle. Latin America is a big and diverse region with cultural, political, economical, heterogeneous conditions, specifically in palliative care. What are the challenges of Latin America as a region to be able to grant quality, universal palliative care services? Great question.
Well, thank you so much for the question. And I wish I had a simple answer, but I don't. And the truth is that what I think is that we're actually a very heterogeneous region, but we are a very creative region. And we have very, very, very opportunity to create and innovate in the application of some things and to use the resources that we have. I think it's very important that we acknowledge that we have a legal framework, and there are a lot of countries in Latin America that do have some laws on palliative care and some availability as a legal framework. I do believe that it is important to improve the policy, the public policy, because if we don't have the public policy, we won't be able to have something to address when we go to the government and talk to them. The other thing that is very important is that the power of the community in Latin America is very, very high. It's very, very important. So I think that we have to train and we have to teach, maybe not just train, but share our experiences with the communities. If you have a successful experience of palliative care with the community, they will replicate it. And since we have a lot of power in our community and we talk a lot within each other, I think that's a very powerful resource because they will ask for palliative care. The other thing that I think it's very, very problematic in Latin America is that we have a lot of problems with access to medication. And some of that is based on the stigma that we have as producers of some drugs that are not correct to use. And then we have all the stigma that we're producing it. So we don't like medications. And there's a lot of confusion between drugs and medications for pain relief sometimes in Latin America. And I think that's a problem that we have, and that's a stigma that we have. The also think that it's very important to recognize is the results within the region and within the countries, because they're very different. We are a developing country, so and a developing region. So we have regions that have high income, some that have middle income, And then we have very, very poor areas in our countries. And we have to try to address that in a multi-level and different way. I think also that it's very important to generate and to create strategic alliances within the countries so that we can advocate to the Pan American Association for Health, to the PAHO, and to address this problem, because so far we haven't. So one of the things that we're doing through the IAHPC, which is the Latin America Association of Palliative Care, is creating this advocacy group so that we can actually address these issues to the PAHO. And I think that's very important as well. Thank you very much.
Danielle, do you want to add to that?
I think I don't need to add anything. She talked everything about the limited resources, unequal access, cultural stigma that we have about opioids, and talk about DIE and the limited education and training, and about the need of policy and regulatory framework. She talked everything. I think thank you so much for advocate for us, Maria.
Catherine?
Very briefly, I would just also recommend, as Maria Leida mentioned, that organizations, first of all, the theme of this webinar seems to have been you need a national association. That's true. But the national associations need to then use their regional associations, as she said, ALCP in Latin America, Asociación Latinoamericano, but then also join the global associations, because that will allow you to advocate at the global level. Come to the World Health Assembly if you can. And that's, for instance, where Hanan, coming from Bethlehem, was able to meet her health minister, because she couldn't meet her health minister in the Palestinian territory. She had to go to Geneva. So there's advantages of every level of the system. And it's really important to have a supportive network globally, regionally, and nationally.
Yes, and I hope you can see from this webinar today the power of having that network as we have come together from all over the world on this particular session. I have another question for you, Joseph, which has come from Edwina, who's in Ghana. And she says, we have struggled to fully activate our national association from lack of funding. How is the new Zambian Palliative Care Association funded now that its activities are integral to the strategy? Thank you.
Yeah, thank you very much for that question. We, from the story of the Palliative Care Alliance in Zambia, it was mainly donor funded, and most of the palliative care work in the areas were premised on the HIV pandemic before the treatment era. And as such, there was a lot of need for palliative care for patients to have advanced HIV disease. But unfortunately, when the landscape for HIV started to change with the advent of ARVs, we saw that the interest to support end-of-life care for HIV was no longer there, was no longer a donor priority, but instead to advance resources towards the treatment aspect of HIV itself. So that's how PIC has reduced its activities and eventually became inactive for close to 10 years or so. What did that entail? We had a gap in advocacy. So learning from this experience, what we'll do differently this time is we want to focus on local resources. So the membership for the Zambia Association, the Zambia Hospice and Palliative Care Alliance, which we are calling ZAPCA, is primarily focused on other associations that are self-sustaining, that have been self-sustaining for a while, that are able to raise own resources. As you saw from the presentation, I'm coming from the Zambia Medical Association, and we were deliberate when we were developing the palliative care strategy, which of the health organization was more stable, had maybe better audits in terms of accounts, who had received funding from other institutions such as the American government. And at that time, when we did our survey, we had the General Nursing Council of Zambia, the Zambia Medical Association, that we thought could work as the secretariat for the Zambia Association for Hospice and Palliative Care Alliance. So that was a deliberate move because we knew that using these platforms, it will be easier for us to begin to raise resources. And even in the event that we didn't raise any resources, we know the Zambia Medical Association or the General Nursing Council will be in a position to anchor the activities of ZAPCA. So it is through the Zambia Medical Association, for example, that we have been able to receive a total grant of $27,500 in the last 4 months or so because of their good financial keeping records and also being a voice in terms of health services in the country. So that to avoid the situation that happened with PCAS, when all the funding went, we couldn't do anything. But this time around, even without funding from external sources, the Zambia Medical Association, as well as other institutions and other members of ZAPCA will be able to provide a platform through which palliative care services advocacy can proceed. Then on top of that, we also have the government has got resources in their health systems to support palliative care. For example, under the Cancer Diseases Hospital, there is a budget for palliative care activities, both at institutional level as well as at advocacy level point of view. So we'll just try to synergize these resources that are in country internally to support palliative care integration. We don't want to go back to the experience that we had from the story that we have from PCAS. It may not be the same if we didn't have a few people that were still passionate about palliative care and continued to push palliative care services, the need for palliative care services to continue in country after PCAS was gone. It's 10 years ago since we had PCAS, but we have still managed to score strides, and we don't want to make that same mistake. Hence, ZAPCA is premised on already existing associations that are both established by the statutory instruments of the government, which government is mandated to fund them. And as such, we hope to see an association that will move through, that will stay alive in the next coming years. Thank you.
Thank you. So I'm going to take one last question, and I think this is one that all of us on the panel can probably give an answer to. Does the private sector have a key role to play in advancing palliative care at a national as well as a global level? Does anybody want to join in first on that one? What's the role of the private sector in advancing palliative care at both a national and a global level? Hanan, do you have any experience in your setting with the private sector?
Actually, when it comes to private sector, they are offering a lot of the healthcare, what is needed, but it can't be on the national level because the private is out of pocket. For those, it will be inequity for patients. So I don't think really the private will be a good setting. We need to get palliative care within the strategy of the Ministry of Health. This way we could move it forward. I could see a lot of patients not getting a treatment because they can't afford it. And with the private, it's always a paid services. So no, it won't help.
Catherine, I noticed you put your hand up.
Thanks, Victoria. Hanan, you're absolutely right in terms of the equity issue. However, that said, only 14%, according to WHO, only 14% of the people in the world with palliative care needs can access it. So we're in an all hands on deck situation. Everyone is needed to cooperate. One of the issues we have with the private sector is with the pharmaceutical industry, because they're not stepping up the way we'd like them to in terms of their social responsibility to manufacture and distribute generics such as oral morphine. Instead, they, of course, because it's the logic of industry, want to sell their expensive patented medications like OxyContin and fentanyl. So you're getting the more expensive meds instead of the generic affordable ones. That's a huge issue, but there is a role for the private sector if there's good oversight and if there's good evaluation and integration into the system with good support from the government for the public sector. So it's all hands on deck. That's my take on it.
And Danielle, I noticed you had your hand up.
Ah, yeah. Just for tell that, oh, just a moment. I show in my presentation a hospital that is the best hospital of my country, is the hospital of our president. And this hospital played a significant role in this matter, because they provided they had a plan to teach palliative care in Brazil, and they are helping with financial resources and also with the professionals, giving the license for the professionals actually in this teaching. They are very good. I think we can have it.
Okay, that was a really great question. And I hope we've answered it there. I guess the answer to that one is yes, the private sector does have a role, but we need to make sure that we know what that role is and that they are fulfilling the obligations, as Catherine's highlighted there. So there are no more questions. And with that in mind, I am going to properly finish the session now. Although we have run over, I think it was certainly worth it to hear those questions. As I said in my presentation at the beginning, the International Association for Hospice and Palliative Care is a global organisation, and we are open to your membership. We welcome your membership. I have a link. Catherine, shall I share the screen again? Yeah, I knew she was going to say yes. Okay, here is the QR code that will take you to our membership page, and here is a link to the homepage for the website. And also, I noticed Natalie is on the call. So we have, am I sharing the correct screen here, or are you getting the screen with all my notes on it? I think you're getting the wrong one. Anyway, here's Natalie, who is on the call, who has been a fantastic delegate for us this week at IAHPC, along with Hanan and Kristen. So thank you very much for that. Very important work that we are doing, and we welcome you as part of this. Okay. So I'm now going to close our webinar, and I want to just echo one phrase that came across very clearly, and it was in Joseph's presentation when he shared with us the paper that got published. Can you hear us now? Let's hope that together, the people who need to hear us can hear us, and together our voices can only get louder. Goodbye. I wish you all a good day, a good evening, and a good night wherever in the world you are.